Hello everybody. Today we are going to discuss about acute fatty liver of pregnancy. Acute fatty liver of pregnancy is the serious and the rare pregnancy related to a liver disease. Acute fatty liver of pregnancy resulting into the hepatic failure in medical and the obstetric emergency. Incidence varies from the 1 in to 7,000 to 1 in to 20,000 pregnancy. It is most strongly linked to the fetal homozygous mutation for long chain 3-hydroxyacyl coenzyme dehydrogenase. This leads to the accumulation of the fatty acid metabolite in the placenta, which then shunted into the maternal circulation and accumulate into the maternal liver. Mother is typically heterozygous for this mutation and also has reduced fatty acid oxidation. However, women who are negative for the mutation can still develop acute fatty liver of pregnancy. Other risk factors include multiple pregnancy and male fetus. Now about diagnosis, acute fatty liver of pregnancy may present with the non-specific symptoms such as nausea, vomiting, headache, anorexia, and abdominal pain. Some women will rapidly progress to the liver failure with hepatic encephalopathy, jaundice, hypoglycemia, and coagulopathy. Symptoms almost always develop in the third trimester. However, cases have been reported in the late second trimester or the postpartum period. There is also association with the preeclampsia, but the reason for this is not well understood. Biochemical test also shows the raised AST, ALT, bilirubin, creatinine, ammonia, lactate, and the serum uric acid. Aminotransferases are usually in the range of 300 to 500 international unit per liter. Hematological tests typically demonstrate a leukocytosis, how low to normal platelet, and the normocytic normochromic anemia. The coagulopathy is usually severe with the prolonged prothrombin time, hypofibrinogenemia, and the elevated D-dimer. Coagulopathy or DIC occur in approximately 70% of cases. The role of liver ultrasound is unclear as prospective studies showed that only 25% of female had classic echogenic finding. CT scan is more sensitive, however, only 50% of cases show typical feature on the CT scan. Liver biopsy is not required to confirm diagnosis but can be useful in indeterminate cases to guide the need for early delivery. Acute fatty liver pregnancy can be challenging to distinguish from the HELP syndrome as they share many clinical and lab features. Female with the acute fatty liver pregnancy are more likely to have synthetic liver dysfunction with coagulopathy, hypofibrinogenemia, lower cholesterol level, high bilirubin level, hypoglycemia, hepatic encephalopathy, hyperammonemia, DIC, and more severe AKI. Other differential include HOS, TTP, paracetamol toxicity, exacerbation of SLE, overlap with preeclampsia, and HELP syndrome. Now, the Swanesia criteria is validated system to help diagnose acute fatty liver of pregnancy, but only in the absence of other liver disease such as HELP syndrome and thus limiting its application. One recent study found that Swanesia criteria were fulfilled in the female presenting with any cause of ALS. Now, this Swansea criteria for diagnosis of acute fatty liver of pregnancy. So, first is symptomatic criteria is vomiting, abdominal pain, polydipsia, polyuria, encephalopathy, elevated bilirubin of more than 14, hypoglycemia, elevated urea, leukocytosis, elevated transaminases, elevated ammonia, renal impairment, creatinine more than 1.5, coagulopathy, elevated prothrombin epitete, ascites or bright liver on the ultrasound scan, microvesicular steatosis on liver biopsy. Now about management, delivery is the only curative treatment as the liver failure will continue until the fetus has been delivered. Before delivery, maternal stabilization should be achieved with the correction of hypoglycemia, coagulopathy, and hypertension. Maternal intensive supportive care is in multidisciplinary team is required following the delivery. 6-hour LFT and the renal function and hematological parameters should be performed within the first 24 to 48 hours after delivery. In a non-randomized trial, plasma exchange have been associated with hastening hepatic improvement and decreasing intensive care stay, but not with improved maternal mortality. Patient with ongoing deterioration in the liver function after emergency delivery or patient who develop hepatic rupture should also transfer to the liver transplant center for assessment. Transplantation should be considered in case of ALF or hepatic rupture. Elevated lactate with hepatic encephalopathy appear to be best predictor of maternal death or need for liver transplantation in one retrospective study. Thank you guys.